Most docs think they're doing prevention when they're looking for tissue damage. Tissue damage always comes from previous metabolic damage, like undiagnosed prediabetes or diabetes. So what we do is look at those labs, look at your metabolism years ahead of time to prevent that tissue damage. Take a look. If you're new to our channel, here's the thing. We're all about helping people understand and prevent the major causes of death and disability. So believe it or not, there are very few major causes. Carb metabolism problems are the biggest ones. Several ranges, ranging from mild prediabetes, insulin resistance, up to significant diabetes. And we have all levels of that with our patients. Unfortunately, it's been shown that the evidence is very clear that 2/3 to 3/4 of docs, primary care, at least in the US, which is supposed to have the best healthcare manpower in the world in this space, 3/4 of the docs don't know how to diagnose it, let alone treat it. So there's a lot of stuff that's very important in medicine that you just got to learn on your own. Empagliflozin and kidney disease is one of our recent topics. Why? What has that got to do with it? That deals with this number one cause, diabetes, prediabetes. A new lean mass hyperresponder study, which we covered a couple of weeks ago. What's that got to do with this topic? Well, it turns out when people go on low-carb diets, some people, depending on their genetics, actually begin to drive their energy metabolism through LDL transport. And what happens is, instead of their LDL, quote, bad cholesterol, which is not bad, that LDL goes way up. And the question is that really unhealthy, like the vast majority of the population of doctors thinks? If you go back and if you look at my life, every month or two, I get a call. It's a panic. It's from someone who has gone low carb. Their LDL shot way up. They panicked. Their doctor panicked, wanted to put them on 40 or 80 of Lipitor or 40 of Crestor. And it's like, whoa, slow down. That's not necessary. So again, there's just time after time where this stuff comes up, especially as we get past age 40. So that's what we're all about. I mentioned the courses. We've got 4 core courses. One is insulin resistance, which we've already mentioned. One is cardiovascular inflammation, where we actually show photomicrographs of the immune system attacking plaque in people's arteries. A third core item that docs just don't know that much about is how to evaluate plaque. The go-to is, well, first of all, let's start with a Framingham evaluation. And the Framingham is almost always done in the doctor's head and wrong. But even if he did it right, Framingham is wrong. It's the data that it's built on is usually too old. For example, it doubles the risk estimates, especially for women. Then after starting with Framingham, the next step is usually, okay, well, let's get a stress test. Stress tests only are positive if you have 50% or more occlusion. 2/3 of heart attacks occur in people that have less than 50% occlusion. So it's a flow study. It's looking at whether or not you have flow. And flow of blood is not a great predictor of heart attacks. That's exactly what happened with Tim Russert. He had a perfect stress test, did well because he was a runner. But he still had that inflammation, that acne-looking pustules, dropping pus into his arteries and forming a clot and killed him. And the worst thing, after that, the incorrect Framingham, after the incorrect stress test, then the next place is to take it to the cath lab. And all of those are just like an evil triumph. There are better ways to evaluate plaque.